Let's go to a PCL question here. A 23-year-old collegiate soccer player sustained a right knee injury 6 months ago. He has been treated with rest and rehabilitation, but is unable to play at his previous level due to his knee giving way. A physical exam reveals 10 degrees of varus malalignment, or 10 degrees of alignment when standing, and a varus thrust with walking. Strength is full compared to the other side. Ligamentous exam reveals a stable ACL and MCL, but opens to a varus stress and a 3+ posterior drawer, and positive dial test at both 30 and 90 degrees of flexion. What is the best treatment option to allow this patient to return to competitive athletic activity? And the answer is number 5, high tibial osteotomy to increase tibial slope and correct varus alignment, reconstruction of the PCL and posterior corner. So let's talk about the PCL. It's an injury that can be isolated or combined. It can happen in 5 to 20% of all knee injuries. It occurs by a direct blow to the proximal tibia, in other words, a dashboard injury. This can also happen with hyperflexion with a plantar flexed foot. The PCL is the primary restraint to posterior tibial translation, and isolated injuries cause the greatest instability at 90 degrees of flexion. This can be associated with other ligamentous injuries like a posterior corner injury and a chronically deficient PCL absent knee. This can lead to increased pressures in the patellofemoral joint and lead to medial compartment wear due to varus alignment. The anatomy, the origin is the posterior tibial sulcus below the articular surface, and it inserts on the anterolateral mediofemoral condyle in a broad crescent-shaped footprint fashion. PCL is a much stouter ligament, 30% larger than the ACL. We talked about the 2 bundles earlier. The anterolateral is tightened flexion. The posterior medial bundle is tightened extension. So again, the way I remember this is AF, like atrial fibrillation, anterolateral flexion, and PE, posterior medial tightened extension. We talked about the ligament of Humphrey and Risberg, which originate from the posterior horn of the lateral meniscus and insert into the PCL substance. There is a classification of injury, grades 1 through 3. Grade 3 is greater than 10 millimeters of posterior tibial translation. These will present with a history of either a dashboard injury or a hyperflexion injury, and symptoms will include posterior knee pain as well as instability. On physical exam, they'll have laxity at 0 degrees, which indicates a collateral ligament injury and PCL injury. But if it's lax at 30 degrees alone, this just indicates a collateral ligament injury. There's a posterior sag sign, as you can see on that picture there, where the medial plateau is posterior to the femur, and the posterior drawer test is another easy test to diagnose the PCL, where you have a directed force applied to the proximal tibia, and you'll see posterior translation of the tibia for about 1 centimeter. There's also the quad activation test, where you attempt to extend the knee, flex 90 degrees to elicit quadriceps contraction, and it's positive if there's anterior reduction of the tibia, which occurs relative to the femur. The dial test is a test that's commonly asked on the boards. If there's greater than 10 degrees of external rotation asymmetry at both 30 degrees and 90 degrees, this is consistent with the posterior corner and PCL injury. If it's greater than 10 degrees of external rotation asymmetry at 30 degrees only, this is consistent with an isolated posterior corner injury. So this is worth knowing for the test. Imaging includes standard AP and supine lateral radiographs, and you can also assess for posterior tibial femoral subluxation on these views. There's also some stress views, as you can see nicely depicted by those 4 radiographs, where you'll see asymmetric posterior tibial displacement, which indicates a PCL injury. An MRI will give you some nice images of the actual ligament. Non-operative treatment will be indicated for grades 1 and 2. And if they're involved in sports, they can return to sports in 4 weeks. For grade 3 injuries, you can immobilize these patients for 4 weeks, and you would immobilize these in extension, and afterwards you would rehab these patients by strengthening their quadriceps muscles. Operative treatment is indicated if there's combined ligamentous injuries, so if the PCL and ACL or posterior corner is injured, or in conjunction with collateral ligament injuries. Operative repair is also indicated for isolated grade 2 or 3 injuries with a bony avulsion, or in chronically deficient PCL knees with a functionally unstable knee. Techniques include primary repair of the bony avulsion fracture with OREF, where you can simply take a screw and tack down the avulsed piece of bone. Reconstruction options include the tibial inlay versus the transtibial technique. More recently, there has been talk of double bundle as opposed to single bundle, and you also have graft options like autograft versus allograft. So in terms of outcomes of different surgical techniques, if you just repair the PCL ligament, these are typically not successful. So reconstruction has better outcomes. Success of reconstruction depends on addressing concomitant ligament injuries, so you don't want to miss other ligament injuries. High tibial osteotomies can be indicated in chronic PCL deficiencies. You can consider a medial opening wedge osteotomy to treat both varus malalignment as well as PCL deficiency. And when you perform a high tibial osteotomy, the reason why this works is because you increase the tibial slope, which helps reduce the posterior sag of the tibia. The transtibial arthroscopic technique involves using an accessory posterior medial portal. This posterior medial portal is placed 1 centimeter proximal to the joint line posterior to the MCL. And if you're sticking a scope in the posterior medial corner, it's helpful to use a 70-degree scope to really to look around the corner. The technique of transtibial drilling is anterior to posterior, and when you tension and fix your graft, you want to do this in 90 degrees of flexion with the anterior drawer, and this results in knee biomechanics similar to the native knee. The open tibial inlay technique that uses a posterior medial approach between the medial head of the gastroc and the semimembranosus. For the pros and cons, there is an advantage to the open tibial inlay technique because you avoid that killer turn that you have with the transtibial arthroscopic technique. The disadvantage, going back to the slide, is that you're really close to the popliteal artery. The single bundle technique, it's an arthroscopic technique typically, and you're really reconstructing the anterolateral bundle, tensioning this at 90 degrees of flexion. There's been more recent talk of the double bundle technique, where the anterolateral bundle is tensioned in 90 degrees of flexion, and the posterior medial bundle is tensioned in extension. Rehabilitation postoperatively really focuses on quad rehabilitation. Some of the dangers that can happen with PCL reconstruction, the popliteal artery is right behind the PCL, so there's always risk of vascular injury. There's also complications of patellofemoral pain arthritis with a chronically deficient PCL knee.
If you enjoyed this video, please consider leaving a like. We'd love to hear your thoughts and what you'd like to see next in the comments. Don't forget to subscribe to our channel and follow us on social media.